Today on Primary Care, hypertension or high blood pressure, a silent killer that many refuse to acknowledge.
I just didn't see where I could have high blood pressure.
Hello, and welcome to Primary Care, where each week we focus on a topic that impacts the health and care of patients, especially African Americans. I'm your host, Dr. Lonnie Joe. This week, we turn our attention to what is described as the silent killer, hypertension or high blood pressure. Many doctors see high blood pressure as the calm before the storm. Left untreated, it cripples and kills by way of heart attacks, strokes, kidney failure. Today, we're pleased to be joined by Dr. John Flack, professor of medicine and physiology at Wayne State University School of Medicine. John, welcome to the show.
Thank you, Dr. Joe.
Good. John, let's not assume that our viewers know what hypertension is. Can we get a layman's explanation of what hypertension or high blood pressure is?
Sure. When the heart pumps blood out into the blood vessels, it creates pressure. And the stiffer those blood vessels are, the more pressure that builds up inside of it. So when you get your blood pressure checked, you are essentially checking the pressure inside of those vessels by a very neat way of measuring it with the blood pressure cuff. And the higher the number, the higher the pressure inside those blood vessels. You don't want too high a pressure in those blood vessels because it will damage the blood vessels. And those blood vessels are carrying blood and delivering oxygen to vital parts of our body like our brains, our kidneys, and that's why those organs fail when your pressure's high.
Now, we're victims in this country of the commercials. All of us have at least 2 or 3 pieces of exercise equipment in the basement, in the garage, and various other places in the home. Right. Talk to us about how diet and exercise in particular plays a role in the treatment of hypertension.
Well, diet and exercise is very important, and the things that you do to prevent hypertension are essentially the same things you do to actually treat it once you have it, plus take your medicine. What you want to do with your diet is restrict sodium, and the hard part about restricting sodium is that it's in the food, most of it before we see it, about 70–75% of it. But on the other hand, the easy part is that it is concentrated within about 10 different food types. Fast foods, pizzas, processed meats like bacon, ham, salami, sausage, a lot of things that people consider good stuff, pickles. And so you have to avoid certain food types, and it's not that you totally avoid them, it's that you cut down. So what I try to get my patients to do is say, I'm eating this much of these 10 different foods, I'm going to try to cut down by 1/3 to 1/2. It's not about being perfect. Exercise, particularly aerobic exercise like walking, running, cycling, anything that you do that gets your heart rate up is very good for blood pressure, even if you don't lose weight. Weightlifting is a mixed bag. Light weights are good. Heavy weights are problematic because they raise your blood pressure not only when you're lifting the weights, but even in between weightlifting sessions. So if you're going to do weights, light resistance training, mostly aerobic exercise. Diets that are high in potassium tend to be low in sodium, fruits, vegetables, things that we were told a long time ago by mothers, grandmothers, and parents, they're good for you. Obviously, if you can eat more of that and less of processed meats and fast foods, you're going to be better off. If you're physically active, you're going to probably maintain your body weight better. Becoming overweight is something that also will raise your blood pressure. And it's just a variety of things between the stress, the diet, and our lifestyle that makes us at high risk for high blood pressure.
How are you getting patients? And I know you guys have a variety of approaches depending on what you see, but how are you getting the average patient to buy into this disease state? Because right now, our main focus is getting to target, getting to goal, and it usually involves medications. And with patients being resistant to adding on another medication or taking medication at all, how are you getting patients to buy into this?
I try to understand what it is that they are thinking about hypertension and listening to them And then I try to creatively dissolve those barriers away. So one barrier about getting people to do diet and lifestyle is that when they don't want to take medication, the more diet and lifestyle changes they make that will lower blood pressure, the less medicine they have to take. So it's something they can do to actually lessen their dependence on medicine. The other thing is that I try to get them to understand that the label silent killer is a mislabel, because many patients do have symptoms. They have headaches, they have sleep disturbance where they will particularly wake up early at night. They have weakness, fatigue, occasionally chest pain that has nothing to do with your heart arteries being clogged. And those things get better when you treat the blood pressure. Well, think about what people will do and spend to feel good. And when they figure out that part of the reason I'm not feeling good is my high blood pressure, it's not just the medicine I'm taking, I think they're more open to actually doing things to control it with diet and lifestyle. I think the other thing you have to do is put them at ease, because many of them are very fearful of high blood pressure, as they should be, because it's linked to stroke. And everyone knows someone who's had a stroke and seen their face drooping, their arm, can't move very well, walking with a cane, because stroke typically doesn't kill, it actually cripples or maims if it's clinically evident. And really trying to get people to take their blood pressure medicine so they avoid a stroke, or if they've had a stroke, clearly let's get your pressure down so we can minimize your risk of having another one.
Right. I've had lots of stroke patients tell me I'd rather take my chance with a heart attack as opposed to living with this stroke.
You're absolutely correct. I asked a group of cardiologists once, I was giving a talk in Chicago, had a room of 125 cardiologists, and asked them would they rather have a heart attack or stroke. There were only 2 people who actually felt that they would rather have a stroke.
The resistance that we see from patients, as you said, they should know the sequelae.
Yeah.
We're not badgering, but we want them to understand exactly what we're dealing with in terms of hypertension that goes untreated or improperly treated,
right,
and the outcomes in terms of eye disease, kidney disease, peripheral vascular heart disease. All the organ systems basically get involved when hypertension is not treated properly.
Yes.
Good. Great. We're going to take a short break. And when we return, primary care will continue, and we'll look at a woman who for 2 years ignored her doctor's warnings about her high blood pressure.
Since 1918, the Detroit Medical Society has been there for physicians, patients, and the community. We were there then, and we're here now. The Detroit Medical Society, here for you.
Welcome back to Primary Care. Leela Rucker was in denial about her high blood pressure and even refused to take medication. She's over that now, but it wasn't easy.
I have an excellent doctor, first of all. We have a good communication, he and I. So when he first broached high blood pressure to me, and I looked at him, I said, that's not happening. You know, I don't have high blood pressure. I said, everywhere I go, my pressure's fine. And people are surprised because even though I'm overweight, they say, wow, your pressure's good. And he was saying that for a while. And I felt comfortable with that. So the first time he said that I needed to consider taking medicine, I said, that's just not going to happen. I said, I feel fine. There's nothing wrong with me. And my numbers look good and so forth. So I fought him for about 2 years. I'm blessed that I didn't have to go to the doctor every week or every month. So I would see him at my physicals, and that's when he'd tell me, I want you to consider this. You really need to be on these pills. And I would say no. And a year ago, he wrote me a script. He says, well, take this home, and I want you to get it filled. So I did get it filled one time, and I took the medication, and then I didn't take it anymore. He was upset when I told him that I stopped. He says, this is not a joke. You really need to do this. But I didn't go back on. And I know I'm sounding kind of foolish here, but I just couldn't see that I had a problem. I did have an occasion where I'd feel dizzy sometimes. I'd have to stop and sit down. I didn't feel well for a moment, but it would pass. I get shortness of breath, and I tell him about it. So this year, when I went to him, I was getting ready to have surgery on my knee, and he started talking to me. He says, you know, you really got to consider the things I'm telling you. I want you to, he said, do you know that you could have a stroke? Do you know that you could die? he just started talking to me one-on-one. And I said, it could happen. And I said, but I don't see it. He says, I want you to really consider this. You have some problems in your heart. He just kept talking about my total condition. My cholesterol was high, and the bad number, the LDL, that number was not going down. It was steadily going up, and he had been after me about doing that. And he said that if I took the medication just for a little while, I would see a difference. So this year, I did listen to him, and I did get my scripts filled, and I have taken the medication. Getting the rest and taking the medication, I do feel a little healthier. My pressure wasn't off the chart, but it was climbing each time, and he had a concern for that. And out of that, I can see that there is a difference. We need to learn to listen to our bodies, and that's a true point. I know that I'm not like I was when I was in my 20s. I know that I have slowed up and things aren't working as well. And just because my body is not doing some things doesn't mean that I'm not healthy. It means that I need to do a checkup to find out what's going on. I don't claim any of the illnesses that I've had. They're not mine, but they do come upon me. But with the doctor and my faith in God most of all, God put these doctors here with this wisdom and knowledge. So if I believe that, I can go to a doctor, and I'm fortunate that I have good doctors and that I have faith and confidence in. Talk with them, and what I do is, with the knowledge I have about my own body and with the knowledge that they have given me about their medical opinion, and in prayer, that's a good combination, and it makes me do what's right. I got rid of the pride about the blood pressure medication or my belief that I'm okay, and I really wasn't. And out of that, I'm able to go ahead and do better. But believing that my doctor has my best interest at heart, believing that I know my body, and most of all, that God is in this picture, I will get better. But to ignore it is foolishness.
Dr. Flack, Mrs. Rucker had a good working relationship with her physician, a good responsive patient, but with the new diagnosis of hypertension being introduced to her, there's clearly an element of denial and pushback on her part with her doctor in terms of treatment.
Yes, and she really reflects something that I see. First of all, she's a bright lady, and so it clearly wasn't because that was a problem and the reason she didn't get it. But she did kind of what smart people sometimes do. They outsmart themselves. She said, look, I'm overweight. My blood pressure's been okay, but now it's up. And the part of the denial was that she's probably getting it checked enough that she just caught it at the time and started going up, but she really overweighted the past as opposed to the new, okay, and didn't believe it. And I think secondly, she believed that she didn't really feel bad, so she couldn't really have a problem. And some people don't feel bad or have symptoms that they recognize as being related to hypertension. And in a way, they're kind of the worst because they can kind of kid themselves because if I don't feel bad, why do I need to treat my blood pressure? And so for her, she probably had an aversion to taking medicine. She trusted her doctor. She believes in God. But I try to get my patients to believe. I believe in God too, but I think God works through others to accomplish the things that He wants to happen to us and allows others to help us help ourselves.
That's key.
That's key.
That's key. So she had symptoms though.
Right.
She had some dizziness. She had some shortness of breath.
Right.
She admits to being overweight. You commented earlier how it is not necessarily a silent killer. There are some side effects that from this disease state that people will experience.
Yeah, like every myth, there's a grain of truth in it. And there are people with high blood pressure, severe high blood pressure, who have absolutely no symptoms. We've done research in this area. We know how to get those symptoms, and some people have none. They're probably the minority. A large number of people have symptoms, but they don't recognize them as symptoms of high blood pressure. And when they do recognize that they have these symptoms, if they're taking blood pressure medicine, oftentimes what they do is blame the medicine. Can't be the high blood pressure because it's silent, and it becomes kind of a circular argument. But yeah, she had some symptoms, and her symptoms were a little bit different in that they were episodic. They weren't persistent, and they would kind of come and go. Many of the patients I see, their symptoms are persistent until you get their pressure down, and then they look at you like they think you're Houdini because you told them you're going to feel better in all likelihood, and they do. There's one caveat. Sometimes when the blood pressure comes down, patients feel worse as their body's adapting and getting used to the lower pressure before they get better. Okay, and I always warn them about that, and I can't tell who it's going to happen to.
Now, her doctor sort of gets tough with her. He pushes the envelope even further. She's getting ready to have knee surgery,
right.
And he's saying, look, your risks of having a stroke is going to be even higher because your blood pressure is not controlled. And this we see in a lot of patients in terms of a lot of preoperative workup, of course, but the risk is there, the risk is clear. How can we actually look at these patients from the standpoint of view of helping them understand the risk, especially as it's associated with other comorbid states like Ms. Rucker had? She has hyperlipidemia, okay, which is part of the so-called deadly trio. But here again, you know, this was an opportunity, and her physician did the proper thing by helping her understand that this thing has changed. It's not just your numbers anymore, it's your numbers plus, and the risk factors are there.
You know, I don't know if there's any magic beyond talking with patients, not trying to be alarmist, but to tell them, you know, what they're at risk for. And the older you get at any given level of blood pressure, the higher your risk goes. For her, the one thing I would have emphasized with her is not only you're at risk for stroke, but given her body size and her blood pressure, she's got a very, very high risk, much higher risk than normal for developing heart failure. Heart failure where the heart either doesn't pump well, or heart failure where the heart pumps okay, but it's so stiff that it causes literally the same symptoms as a poorly pumping heart. And those things are preventable. And the tragic thing about high blood pressure is we have over 100 medications. We have new devices coming out. We have medicines that you can get for $4 a month at some of the discounted generics in the discounted places. And it's still hard to get patients at times to take their medicine, but I don't think there's anything that substitutes other than talking and understanding.
Right, educated patient, a better patient.
Put them at ease, and you know, don't refuse to see them because they won't take their medicine. I know doctors who sometimes will do that, and I think that really defeats the purpose.
Right. Good, very interesting. We're going to take another short break, and we'll be right back with Dr. Flack and more on primary care.
This is where heart doctors throughout the Midwest are bringing their toughest cases, where specialists from around the world come to learn, where patients who couldn't be saved before are being saved. The all-new state-of-the-heart DMC Heart Hospital. This is Detroit, rising, medicine advancing, the future unfolding. The new DMC Heart Hospital. This changes everything.
Welcome back to Primary Care. We're on set with Dr. John Flack, Professor of Medicine and Physiology at Wayne State University and a clinical hypertension specialist. John, we hear a lot these days about African Americans being salt sensitive, and what has your research really shown about the sensitivity in African Americans as opposed to other populations?
Well, many patients will have sensitivity to salt, which essentially means that when you give salt, the blood pressure goes up. When you take it away, it goes down. African Americans do have more salt sensitivity, whether they have normal blood pressure, pre-hypertension, or hypertension. By the time you develop high blood pressure, though, most patients, irrespective of race, are sensitive to salt. One of the interesting factors that determines how salt sensitive you are was determined in some very nice studies done out at University of California, San Francisco, in Curtis Morris's lab, where essentially they showed that if you raise the potassium intake in the diet above a certain level, which is probably about 2.5 times what most African Americans in the United States take, you can give a person sodium and their blood pressure doesn't hardly budge. So again, fruits, vegetables, rich in potassium help protect you against the effects of sodium. For a long time we talked about salt sensitivity, and people were talking about the genetics of it like it was something you were born with and you invariably had until you went to your grave. And it's not that simple at all. If you lose weight, you can reduce or eliminate your salt sensitivity. If you change your diet, you can do the same thing. So it's a modifiable trait that occurs. But if you are salt sensitive and your pressure stays high because you're constantly in a high sodium environment, then it is going to be a risk factor for all the bad things that blood pressure causes: stroke, heart failure, heart attack.
Salt is ubiquitous.
Salt's ubiquitous.
It's everywhere. What has your research shown concerning our genes or gene pools? We know about African Americans to some degree. Do we see the same thing in other populations, Scandinavians, Australians?
Well, racial categories, despite the fact that science has oftentimes tried to equate those to clean genetic classifications, racial classifications, what we even look like or self-identify as, are very loosely related to what our genetic makeup is. Okay, if you take people who look white and you assay their genes, you will find things called ancestral informative markers that could only have come from an African population, or a population in the Middle East or in the Orient. If you take someone who looks like us and assay our ancestral informative markers, you're going to find African, you're going to find European, you're going to find Indian. And these markers that only occur in certain populations are very rare, okay? So you're looking in large numbers of people, or you're looking for these markers, and you can kind of tell what someone's heritage was. If you go into Europe, Spain, Finland, and Germany, people in those countries have more hypertension and higher blood pressure at every age in adult life than blacks in the United States do. Nobody ever really talks about that. I don't know whether they're more salt sensitive or not, but I suspect that they probably are, because we know that once you develop hypertension, you become really sensitive to sodium. In part, that sensitivity to sodium is why you developed hypertension. So for common forms of hypertension, the genetic risk profile is really determined by a cluster of genes that probably only have 1, 2, at the most 3 millimeters of mercury effect on your blood pressure. But depending on how many of that cluster of genes you get born with, okay, it can start you out at a lower, more intermediate or higher level within the normal range. And we also know from stuff that we're doing, experiments we're doing, and things called Mendelian randomizations, that if you start out on the lower part, your age-related rise in blood pressure is a lot less. If you start out higher normal, your age-related rise in blood pressure is a lot greater. And essentially what it's telling you is that once your blood pressure is even just very modestly elevated, it damages your blood vessels and it causes you to develop more severe hypertension. And I think that our patient that we saw was showing a little bit of that, because every time she went in, her pressure was going higher and higher. It went up and it's kind of staying flat. It's going higher and higher. And that's what you kind of see in patients once they really sort of start losing control, is that they don't have to wait a decade for it to happen. It can happen over months to a year.
What about the role that generics play? We're all cost sensitive.
Right.
We're salt sensitive, we're cost sensitive.
Right.
You know, but in a lot of times this is becoming the bane of our existence in terms of what's available, how much is available, how do we make changes.
Right.
What is your approach in terms of addressing these issues concerning generic medications?
Some of the best drugs that we have available are generic. I have patients who, when first thing out of their mouth literally is, "Dr. Flack, are these generic drugs?" Yes, ma'am. Yes, sir. I don't want them. Why? Because many times they equate the fact that the insurance company is trying to force them to use generics because they want to save money. That's their perception, probably correct. and that if they're forcing them to do it, it can't be good. Well, again, we use generics all the time, and some of the absolute best drugs that we have are generic. What's happened in the last 5-6 years is that drugs losing patent protection, like amlodipine, for example, now generic. These are great drugs. Okay, so the generic pool every year gets better and better and stronger. And in fact, one of the reasons that companies are not investing as much in finding new hypertension drugs has to do with the very fact that the generics have gotten so good and are cheap enough to a point that despite the large market size, 80 million people with hypertension in the U.S., they are loath to invest large sums of money in finding new drugs. Now, it's not that they're not doing it, they're just not doing it to the degree that they were 10, 20 years ago.
Dr. John Flack, Professor of Medicine and Physiology at Wayne State University. John, thank you for joining us on the show.
Thank you for inviting me.
Our pleasure.
Okay.
Thank you for joining us. I'm Dr. Lonnie Joe, and we'll see you next time on Primary Care.
Primary Care was produced with the participation of the Detroit Medical Society, representing physicians, patients, and the community.